Hello. Okay, I want to introduce our speaker, who's Dr. Deborah Kaysen, who is a clinical psychologist and associate professor in our Department of Psychiatry and Behavioral Sciences. Dr. Kaysen has received grants from the National Institute of Alcohol Abuse and Alcoholism, the National Institutes of Drug Abuse, and the Alcohol Beverage Medical Research Foundation. Her work predominantly focuses on interaction between trauma exposure, PTSD, and alcohol problems. She's published over 40 journal articles and was awarded the New Investigator Award for the Women's SIG of the Association for Behavioral and Cognitive Therapies, and an Early Career Poster Award from Division 50 of the American Psychological Association and the NIAAA. So, Dr. Kaysen, please speak with us.
I have a fan club, and I will ask them to be not too rowdy. They also were threatening to do the wave, so I'm trying to discourage this type of behavior. I'm really, really excited to be talking to all of you today. So I'm going to be talking, this is the first major presentation of the first year data collection off of my new R01. And so I'm excited to chat with you all about this. And it's also a topic that I'm excited to have data on, because it's a really understudied population. But we'll be talking a little bit more about that in a second. Before I move forward, I always like to acknowledge the team that makes research happen, because I am not an island. So I first of all want to thank all of my wonderful collaborators, many of whom are either in this room or are following the talk remotely. So this is the executive team who helped make this grant successful. I also want to acknowledge our amazing stats and data team who helped me not embarrass myself by doing stats badly. And I really want to call out my two research coordinators, Jessica Blaney and Kim Hodge. Both of them have been amazing on this project, and they really are the heart and soul of it. And of course, I want to thank NIAAA, without whom none of this would have happened. All right, so why are we here today? Lesbian and gay, bisexual, transgendered populations represent between 1 to 10% of the population. However, this is an area that's been largely neglected in most of the research literature. Sexual minority women were acknowledged as a health disparate group in Healthy People 2010, and they've been identified as a medically underserved population. In a review of the literature over the past 20 years, only 0.1% of all articles in Medline actually mentioned LGBT individuals at all. If you break that down further, more than 80% of those focused on gay men or bisexual men. And of that literature, 56% focused on sexually transmitted infections. If you take together lesbians, bisexual, and transgendered people as a group, they're only mentioned in about 46% of that 0.1% of articles as a group. These are actually very different populations, and by combining them together, it really makes it difficult for us to understand the unique health experiences and risk factors affecting especially sexual minority women. The transgender community also is incredibly understudied. I'm not going to be talking about the experiences of transgender people in this talk, but I think that's also an area that is incredibly, sadly neglected. Sexual minority women, and that's actually the focus of my grant. So for today, I'm going to be talking about the impact of stigma-related stressors on mental health and health risk behaviors. And I'll also be talking about the role of coping motives. So if you look at the early literature on LGBT communities, what you saw was a lot of research that focused on mental health problems, predominantly pulled from clinical studies. Right? You go into a clinic and you sample people who are sexual minorities, and you say, look, there's something pathological about them, because there are high rates of distress, okay, with the very early literature. And it left out the role of stressors, that this may be a community that's experiencing an inordinate amount of stress which may then lead to an increase in mental health symptoms. And this is called the minority stress hypothesis, which I'll be talking about today. Okay. Now, these stressors can also lead to increases in health risk behaviors. I'm going to be talking also about this relationship between mental health and health risk behaviors because in other literatures we consider the idea of self-medication. Okay. That it may or may not be a direct relationship from stressors to increased substance use, or it may be mediated by increased mental health symptoms. Okay. Now, I would also argue that not everybody who has mental health symptoms drinks to cope. Okay. And so I'm going to be talking a little bit about the role of emotion regulation or coping motives in understanding who may be more likely to use substances. I do hope people ask questions as I talk, just as an aside, as a speaker style issue. All right, so this self-medication relationship. In general, especially when you look at the literature between PTSD and alcohol use, we talk a lot about self-medication. So the idea with that is that alcohol use is negatively reinforcing, which means it reduces distress. So if you have a trauma-exposed person, let's say she has a distressing memory of something that's happened, okay? Her distress goes up. Now let's say she has a drink. What would happen? Okay, it would cut off that distress. Okay, so that little curve would go down, but it's going to increase the chances that she's going to drink again in the future, which over time, the theory is, will lead to increased drinking problems. Okay. Now, as we move into this talk, I do want to discuss a little bit about identity. So when we talk about sexual minority women, who are we talking about? Right? So often we assume that behavior equals label equals attraction, but there actually is quite a bit of variability across that. Okay? And this is important when reading this body of literature as well. So this was actually a study where they looked at how many people fit into all of those categories. And what I want you to notice is actually it's a relatively small group where attraction, behavior, and self-identity, or orientation as we often talk about it, all match. Okay? So what slice of the pie you're getting may depend on how you're framing the question. Okay. Now, when we look at a lot of the LGBT literature, there are issues or challenges in, for folks who are standing up, there's actually a bunch of seats down here, and I promise I won't bite.
I'm sitting down, Deb.
That sounds fine, Doug. Karen, there's a seat over here. It's a sign I've been in the department too long when I actually can pick in that many individual people out of the audience and tell them to sit down. All right, so if you look at the LGBT research, one of the issues with hidden minorities is how do you get your sample? Okay. So as I said earlier, many early studies pulled from clinical populations or pulled from prison populations and then said, hey, look. Okay. For example, the Rorschach. Okay. If you look at all of the information about LGBT populations from the Rorschach, it was actually collected from a prison population, just as a random aside. Okay. So more recently, the methodology that's been used is to recruit from community settings, community events, or organizations. So, for example, when I was in grad school, I helped out with a project where we recruited from Gay Pride, right? Because there are lots of gay people at Gay Pride, okay? But they may not be a representative sample of gay people because you got to be a certain kind of person to be out there flying a rainbow flag, okay? So there are a number of issues. First of all, you're going to get more people who are out, okay? You're also going to potentially underrepresent bisexuals. Okay. Many bisexuals feel excluded from the gay and lesbian community, and there actually is a fair amount of discrimination against bisexuals within the community. So if you go to a lesbian or gay event, guess who's missing? Right. And if you look at this literature, most studies do not have enough of a sample of bisexual women to be able to look at their experiences separately from lesbians. There are also large epidemiological studies. Now, up until recently, there was an issue with those. Remember that slide I showed you just a little bit ago about identity, behavior, and attraction? Many of those studies categorize people as lesbian, gay, or bisexual based on sexual behavior only. And that may not always overlap with how someone self-identifies. And there are some studies that have found differences in health outcomes and mental health between people who engage in same-sex sexual behavior versus people who identify as lesbian, gay, or bisexual. Okay. So that was our challenge. In addition, if you look at those large epidemiological studies, and you're going to see a bunch of those slides as we go, even with samples as large as 40 or 50,000 individuals, often the sample size for lesbians or bisexual women is about 100. Okay, or maybe 200. And then when you start to break that down, you're looking at very small sample sizes. So we decided to do something entirely different for our study. So for this study, we are trying to understand models of drinking among young adult lesbian and bisexual women. It's a 5-year longitudinal study, and we wanted to get women from everywhere across the United States. So we used Facebook. Okay. And in Facebook, how many people have Facebook accounts? I know some of you because you're friends. All right. So in Facebook, people can indicate on their profiles if they are interested in relationships with men, relationships with women, or relationships with both. And so what women who were in our age range and who indicated that they were interested in relationships with women received was a little targeted ad. And we tailored the ads to pull for different kinds of women. We also oversampled women who were ethnic minorities. Okay. And they would get this. Now, they might click on that. It would give them more information about the study, and then they could finish a screening, and they could opt into the study. Okay. So I'm going to walk you through this. So as I said, this is a 5-year longitudinal study. We are also getting event-level data. So for a sample of them, we're getting 2 weeks of daily monitoring every year. Okay. Now, what I mean by number of impressions is that is everyone that Facebook tells us could have seen our ad. It is not unique individuals, because the same person may see our ad 20 times. There are some clothing people who appear to really like my profile because I get those same ads every time. So it just says this is the number of times your ad was shown. Okay? This is the number of times the ad was clicked. Okay. And then we completed about 4,000 screenings. And of that, we collected a little over 1,000 women, 1,090. Okay. And then we randomly selected 100 of the heaviest drinkers to do the daily monitoring with. And I'm not going to be talking about that data today, but just to know, in a few years we'll have some conversations about that. Okay. But this is where we're going to be talking today. Now, in terms of who we got, I was pretty pleased with how we did. We got a fairly diverse sample. Okay, so about 72% of the sample was white. We got about 59% of the sample who identified as bisexual, which is actually, I think, the largest sample of bisexual women ever collected. Okay. They're about 20 years old. About 15% are working full-time, and about 66% of the women are in school. So for people who do a lot of research in the emerging adulthood age range, this is also a notable study in that we collected data on quite a number of women who were not in 4-year colleges, which is another really interesting thing to look at, being able to look at young women who may or may not be in college and the impact of a college setting on emerging adult lesbian and bisexual women's experiences. Okay. Now, as we were talking about in terms of identity, when we did a forced choice, 59% of the women identified as bisexual, but when we allowed women to choose whatever label they wanted, there was actually a fair amount of diversity there as well. So quite a number of women chose lesbian, quite a number of women chose bisexual, but we also had women who identified as queer, two-spirit, questioning, and then other. Okay? And then when you look at sexual behavior and attraction, you can also see quite a bit of diversity. Okay. Now, just to show you, again, circling back to that idea of differences between identity and behavior and attraction, when you look at the sample who just identify as lesbian, in forced choice, what you see is that about 74% of women who identify as lesbian based on forced choice would actually be categorized as lesbian based on their past 12-month sexual behavior. So you may identify as lesbian, but you may not be engaging in any sexual behavior right now. It's not always who you do, okay, to be blunt, okay? You may be engaging in sexual behavior with men, but you identify as lesbian, okay? Which, when we think about things like HIV risk behavior, is a risk factor. And we did actually have a small number of women who identify as lesbian but are only having sex with men right now. Okay. So again, when you think about some of those epidemiological studies where they categorize people solely based on behavior, there may be some issues. Okay. And yeah.
Did your screening process take into account that Facebook also forces gender selection, male or female?
Yes. And we asked people gender, but we also asked people to choose whatever label they wanted. And we do have a number of transgendered women in the sample. We have 22. So, but then that got very complicated for these analyses. All right. But yes, as long as somebody identified as female, we took them in this sample. Okay. For attraction, you can see that many of our lesbians are attracted only towards women, but there are others who are attracted mostly towards women. Okay. Now, in terms of our goal of trying to get women from all kinds of places, we feel pretty good about that. So we managed to get people from all over the United States. Okay. And we were able to recruit a good-sized number of women from rural settings and from small towns, rather than just getting people from urban or large cities. Okay. So, in looking at some of the experiences of these women, one of the things that's always interesting is looking at the coming out process, especially with such a young sample. Okay. And what we're seeing is that generally lesbians and bisexual women are coming out around the same time, although the bisexual women are coming out in terms of first wondering about their sexual orientation just a little bit later. And the lesbians are actually having a first relationship with a man a little bit earlier than bisexual women, which is sort of interesting. Well, sometimes you got to figure out what you aren't. You can see Heidi's going, huh? All right. The other thing that we thought was interesting here was that people are doing some sexual exploration a bit before they actually tell someone what their sexual orientation is. All right, so now I'm going to focus in on stressors and talk a little bit, both from this study and from other studies, about the role of stressors in these women's lives. I don't know how many of you have been following the New York Times lately, but actually just this week there was an article about hate crimes in Iraq, and that gay Iraqis are being targeted for victimization because of their sexual orientation. So this is an excerpt from the article. The security officer said that in the past 2 weeks, officials had found the bodies of 6 young men whose skulls had been crushed. Reuters reported the toll to be 14 or more, and some of the NGOs in the region are saying that the numbers are more like 40 or 50. I actually have been involved in a project in Iraq, and we had problems with getting male therapists to work with gay men who had been trauma exposed because of fears that the therapists themselves would be victimized if they were seen with a gay man. And if you think this just happens in Iraq, this is from 2 years ago in New York. The title says, "Lured into a Trap, Then Tortured for Being Gay." This is an experience in the Bronx. Someone was told that he could come to a party. What he walked into was not a party, but a night of torture. The man was sodomized, burned, whipped, and it was punishment for being gay. Okay. This is actually from just a month ago with a young college lesbian. She was assaulted for being a lesbian outside of a bar. The 20-year-old college football player assaulted her because she told him that she was a lesbian. She wound up with a fractured skull, bleeding from the ear, and an extended stay in the ICU. So when we look at hate crimes, About 19% of hate crimes are due to sexual orientation. Some people have said that that's a sign that maybe this isn't that big a deal because it isn't the majority of hate crimes. However, if you control for size of the population, and when you look at the most violent assaults, so physical assaults, not vandalism, what you see is that anti-gay, lesbian, and bisexual victimization, I leave out the transgendered here because up until recently the FBI did not actually track hate crimes against transgendered individuals at all. So there is very little data. The data that is there says that this is actually the group that is most at risk, the crimes are the most violent, and they have the highest homicide rate due to hate crimes. But what I want you to notice is how anti-gay violence is by far the biggest when it comes to things like aggravated assault and simple assault, or if you just look at crimes against people. Now, when we look at things like sexual violence or sexual victimization, there's been some really lovely research that's been done looking at this. So early research found very high rates of victimization within sexual minority women, but these studies also had issues with very small sample sizes and had problems with just the way the samples were collected. A growing body of literature has found high rates of victimization over the lifespan for sexual minority women as compared to heterosexual women. So this is actually data from the National Epidemiological Survey on Alcohol and Related Conditions. You're going to hear me talking about NASARC data throughout this because it is one of the large population-based studies that actually asks about sexual identity. Okay? And what you can see is a significantly higher risk of victimization for the women who identify as lesbian and bisexual. And I want you to really notice those numbers for adult sexual assault. Now, this study is an elegant study done by my friend and colleague Kimberly Balsam. And what she looked at were rates of victimization for lesbians, gay men, and bisexual men and women as compared to their own heterosexual siblings as a way to control for things like family, structure, socioeconomic status. What she found in her study were significantly higher rates of childhood victimization, sexual assault, psychological maltreatment, neglect, and child physical abuse for all sexual minorities as compared to heterosexual siblings. For women, she also found significantly higher rates of child sexual abuse, rape, and a little bit higher for domestic violence for lesbian and bisexual women. Now, for my sample, so again, these are women ages 18 to 25. We're also seeing relatively high rates of exposure to stressors. So in our sample, about 19% of the women have been homeless in their lives. About 22% are currently unemployed, and about 30% currently have no health insurance. 90% of our sample had experienced at least one criterion A traumatic event, and the average was about 5.5. So criterion A traumatic events are things like sexual assault, natural disasters, physical assault, stalking. Okay. When we break it down and look at the rates of victimization, what we see are significantly higher rates of adolescent and adult sexual violence and domestic violence for bisexual women as compared to the lesbian women in our sample. The lesbians had significantly higher rates of crimes attributable to their sexual orientation. But overall, what we're seeing are elevated rates in comparison with heterosexual women. By way of comparison, we used actually the same measures of trauma exposure in a sample of UW college females, which are actually also a group that are at high risk for victimization. And for example, if you look at this sexual assault in here, we had about 38% of the college females who had experienced some type of sexual victimization. Okay. All right. So given the rate of stressors, it's probably not surprising that you might see elevated rates of psychological distress. What we see are that lesbian and bisexual women are at higher risk for depression, anxiety disorders, and alcohol use disorders as compared to heterosexual women.
So just to walk you through some of that, this is actually a meta-analysis of some of the earlier literature that was done. So this yellow line represents the degree of relative risk. So if these numbers were below this yellow line, it would mean that heterosexual women were at elevated risk. Because it's above, it's a higher risk for lesbian and bi women. You can see the higher rates of depression, anxiety, suicide attempts, and suicidal ideation. Now, the one thing I would caution you is that often these are based on very, very small sample sizes. So some of these studies are based on 2 studies. Sometimes the sample size is as little as 100 people, even though this may be a meta-analysis. Okay, so do take that with a bit of caution. Okay. This study here was an analysis of the NASARC data, and again what you're seeing are elevated rates of PTSD and depression, and also relatively higher, significantly higher rates of mood and anxiety disorders among the lesbian and bi women as compared to heterosexual women. And this actually included, this also included men. Now, when we look at my sample, like I said, our study was not set up to do a comparison with heterosexuals. That's just not the goal of what we were trying to get done. But I did include both the screening cutoff for these measures and the clinical cutoff, just so you get a sense of where they fall. We're seeing significantly higher rates of depression among our bisexual women. This actually replicates a finding of one of my colleagues, Tonda Hughes. She's also found higher rates of depression in bi women than lesbians. And equally high rates of PTSD, and I would say that these are relatively high rates of PTSD for young women in a non-clinical setting. Okay. When we move into substance use, in general, the literature tends to find higher rates of alcohol problems and alcohol dependence among lesbian and bisexual women, which is why I'm funded by NIAAA and not NIMH. Okay. So, and you can see here, again, this is from NASARC data, significantly higher rates of heavy drinking, alcohol dependence, and marijuana use. Okay. And again, from the meta-analysis, just to give you a bird's eye view of the literature, this actually was one of their most notable findings, were the much higher rates of alcohol dependence among lesbian and bisexual women when you analyze it across studies. Now, when we move to younger populations, it gets a little bit more complicated. So there do seem to be some indicators of increased risk for college-aged women, but there are a lot fewer studies in this age group. So this was a study done by Ridner looking at college women. They did find higher rates of smoking, drinking, and marijuana use. This I thought was a lovely, lovely study that was done looking at the trajectory or the transition from high school into college for sexual minorities and heterosexual college students. I want you to notice, though, how small that sample size is for the lesbian and bi women. This is 47 women. Okay. But what they found were significantly higher rates in high school of drinking, but no increased drinking once they got to college. Instead, the heterosexual women just began to drink more. Okay. So at this point, they're catching up. Okay. So I think right now for this age group, there's a lot we don't know about what's happening in terms of health risk behaviors. In terms of our data, what we're seeing, which makes me happy and sad at the same time, is that they're actually not drinking that much. Okay. So what we are seeing is for peak BAC, blood alcohol level, they are drinking maybe a little bit more than our heterosexual women, but not much. Okay. Not really any difference in terms of typical BAC, and actually for drinking consequences, they're quite a bit lower than the average for the measure that we're using of drinking consequences. Okay. That being said, there's still women in our sample who are drinking quite a bit, who are having a lot of consequences, but overall they seem to actually be doing okay. Okay. So let's start putting the pieces a little bit together and look at how stressors around stigma and trauma exposure may help explain some of the mental health and substance use findings that we've been talking about. The first thing I want to talk about briefly is hate crime legislation. So many of you may or may not be aware that whether or not a crime is categorized as a hate crime if it happens because of your sexual orientation varies quite a bit by where you live. Okay? So it is better to be on this map in pink. Okay? And that has a profound impact on people's mental health. So this was a reanalysis of NASARC data. What they did is they compared people who lived in states where there were protections around hate crimes based on sexual orientation and or there were protections based on employment discrimination laws. So for example, I went to graduate school in Missouri, and in Missouri, when I was there as a grad student, you could lose your job for being gay. You could lose your kid for being gay. Okay? That has an impact on how people function. And it's nice to have some data that backs that up. So these are the increased risk over heterosexuals of PTSD, depression, and alcohol use disorders if you live in a state with at least one protective policy. And these are the increased risks of mental health disorders if you live in a state with no protective policies.
Deb,
Yeah.
I suppose that could also be a proxy for a variety of other stressors.
Absolutely. Absolutely. There's a lot of reasons I live in Washington State. And Mount Rainier is one of them. Okay. So, discrimination also has an impact on people's mental health and functioning. Okay. So, this is actually, again, a reanalysis of the NASARC data. You can just hit rewind on that periodically. And they looked at individuals. Now, this is not GLBT. This is in general. Oh, no, this is actually GLBT. But it's not lesbian and bisexual. It's all GLBT individuals who reported. And what they found were people who experienced discrimination had significantly higher rates of alcohol use disorders than people who did not. Okay. What I think is even more striking, though, and this answers some of your comment, John, I think, is they looked at, so in 2001, 2002, there was a wave of data collection, and it was before there were a whole lot of defense of marriage constitutional amendments. Okay? And then in 2004, 2005, a bunch of states passed legislation or constitutional amendments banning gay marriage. And in the process of having that discussion as a state, there was a lot of very hurtful, anti-gay advertising, okay, and very negative messaging. And so they looked at the rates of mental health disorders within LGBT individuals from Wave 1 and Wave 2 in states where there was no constitutional amendment and states where there was. Okay. So my guess is not a lot of people moved. I mean, certainly some people moved in those times, but that wouldn't describe all of it. And what you're seeing is greatly increased rates of mental health problems, especially mood disorders and alcohol use disorders, if you were in a state where that was the kind of messaging that occurred. Okay. Just a couple of other points around this same topic of victimization, discrimination, and the impact on mental health disorders and distress. Victimization in and of itself has been related to sexual orientation, has been predictive of mental health concerns among sexual minority women. Child sexual abuse has been found to predict drinking problems, both prospectively as well as cross-sectionally. And I haven't even gotten into the issues around school bullying, but that has been found to be a major risk factor for gay, lesbian, and bisexual youth, both in terms of mental health and substance use and homelessness. When we get into my data, I was a little bit curious, especially given those rates of sexual assault, about the impact of that and the impact of bias crimes. And what I found is that for PTSD, both sexual assault, so whether people had no adult sexual assault history or they did experience an adult sexual assault, we found significantly higher rates of PTSD if you had a sexual assault. We found significantly higher rates for those women who experienced a bias crime. Okay. For depression, what we found was significantly higher rates of depression associated with adult sexual assault, but not so much with bias crimes. Okay. And for alcohol use, what we found was a significant effect across the board for the impact of having an adult sexual assault on peak drinking, typical drinking, and the number of alcohol consequences that people experienced, but no effect for experiencing bias crimes. Okay. So really those rates of sexual victimization seem to be playing a very big role in understanding both mental health distress and substance use in these young women. Bias crimes certainly increase rates of PTSD, but may not be associated with some of the other changes. Keep in mind, though, that for us, those bias crimes carried the gamut in terms of severity, right? So it could be things like somebody, they were all interpersonal aggression, but it included a lot more minor or less serious forms of interpersonal aggression versus adult sexual assault, which is known to have very, very high levels of association with mental health distress and substance use. All right, so let's start putting the pieces together. So what we were wanting to understand was a little bit more about how these associations may fit. And, when you just think about stressors to mental health, stressors to health risk behaviors, it may not talk a lot about mechanisms. So that was really what we were trying to parse out a little bit from this sample. Now keep in mind, these analyses are all going to be cross-sectional because this is just our first year of data collection. So consider this to be a very preliminary peek. Okay. So what we wanted to look at was first the minority stress hypothesis, that the increased rates of trauma exposure and discrimination may lead to increased mental health distress, mental health symptoms, and that those may then lead to increased alcohol use and consequences. We also wanted to look at that self-medication relationship. Is it that mental health symptoms are leading to alcohol use and consequences? And then whether that was moderated by coping motives. So if I don't think that drinking is a good way to handle a bad day, I may be less likely to drink when I'm having a bad day. All right? And some people have higher motives in that area and some people don't. Okay. So in terms of what we found, so we conducted a negative binomial regression path analysis to look at this data. Okay. And first we did a logit model just to look at drinking versus not drinking. Okay. We found, wrong button, there we go. We found a significant relationship between trauma exposure, discrimination, and PTSD and depression, which is really good because I would be very worried about our data if we did not find that. So I was relieved. So people with higher trauma exposure, higher PTSD, higher depression, increased experiences of discrimination in our sample were associated with higher PTSD and depression. We also found a direct relationship from trauma exposure to increased drinking. So in this case, women who had higher trauma exposure were more likely to be drinkers. Okay. We found no significant relationship in understanding whether or not people were drinkers from discrimination or mental health symptoms. Now, when we look at the number of drinks that people consume, what we found was that, again, this relationship isn't going to change these slides. We still found a significant relationship from trauma exposure to the amount that people drink. Okay? And we found that people with higher coping motives drink more. Okay? But there was no relationship between that and PTSD. For depression, what we found was the opposite of what we had anticipated. So women who had higher depression drank less. So different relationship between PTSD and depression in drinking outcomes. PTSD, nothing. Depression, you drink less. Okay. Now for drinking consequences, what we found was still no direct relationship, but we did find that coping motives was a moderator. So if we break that apart and take a look at that interaction effect, what I want you to see, so this top line are the people with high coping motives. These are the people with medium coping motives and with low coping motives. And what you see is that coping motives really do seem to be driving the show. If you have high coping motives, you're going to have more problems when you drink. Similar finding for depression. The one thing about this that was a little perplexing for us, and remains a little perplexing, although we've got some theories about it, is that if you have high depression and high coping motives, you have fewer consequences. Okay. We think that this could potentially be due to tolerance, right? Because consequences don't always relate to how much you're drinking, right? Especially if you've been drinking for a while. All right, so what are the take-home messages? First of all, I hope one of the things that you've taken from this is to be more aware about the high degree of stressors and trauma exposure among lesbian and bisexual women, especially bisexual women, that they really seem to be experiencing very high rates, especially of sexual victimization and domestic violence. When the lesbians are experiencing a higher risk of victimization because of sexual orientation itself. But, this is interesting and maybe a little perplexing. One question was, well, most perpetrators are men. Sorry, guys. Maybe it's that the bisexual women have just more sexual contact with men. The problem with that is then why don't we see higher rates in heterosexual women? Right? You would expect that heterosexual women would be your highest risk group if that were true. One possibility is that bisexual women may have a longer period of identity exploration. Possibly that's due to increased risk behaviors, which may be more likely to leave them in more risky situations. So, for example, we've actually looked at some of the data on alcohol-involved sexual assaults versus sexual assaults where there is no alcohol, and the bisexual women are at much higher risk for alcohol-involved sexual assaults. Okay. For us as providers, I think it's really important to be aware when you're working with clients who are sexual minorities to inquire about victimization and violence exposure. Okay, don't assume, but you definitely want to be asking. Okay. I also think from a public health perspective, this really speaks so clearly for the importance of protective legislation and for changing as a society how we talk about sexual orientation. In terms of psychological distress, really consistently, both across national samples, my sample, we're seeing elevated rates of PTSD and depression. In the national studies, we're also seeing that higher rate of alcohol abuse and problems, but there really is a lack of data on the experiences of young women. Some of that may be a cohort effect, right? So, back in the day, women met women at bars, right? Because there was no place else to meet. Now women meet women on Facebook, right? And so that may be changing how alcohol use plays a role within the community. And it may be changing things in positive ways. Okay. I do think that in terms of the psychological findings, it really speaks loudly for the importance of screening and awareness of clinical treatment options within the community, and for us to really be working with the community to increase evidence-based treatment. And remember at the beginning when I said, we've only got 207 studies on how to provide culturally sensitive care to sexual minorities. We really need to be working around sensitivity and cultural awareness with providers. In terms of models, I do hope that you guys got a sense of how discrimination and trauma exposure are relating to PTSD and depression. And we really had quite a bit of support within this data for that minority stress hypothesis, that this isn't about that this is a pathological population. It is that this is a population that is carrying quite a lot of burden in terms of discrimination. Okay. And again, if we want to reduce PTSD and depression, we need to push for protective legislation. Okay. We did not find a lot of support for self-medication in this sample. Okay, so we need to think about other models of drinking. So my lesbian and bisexual women are still young women, and there's lots of reasons why people drink and why young women drink. So this can be about descriptive norms. One thing that we've looked at briefly within the sample is how much they think heterosexual women drink and how much they think other lesbian and bi women drink. They think lesbian and bi women drink more. that increases your risk for drinking. Okay. Limitations. This is still cross-sectional right now, although we'll be able to fix that. But right now we can't test directionality or causality. It also is going to artificially inflate some of those relationships. We didn't include heterosexuals. I don't actually think that's a limitation in this sample. We had a different goal, but I can't really say whether these models would apply to heterosexual women. And then the internet. So this gave us a big sample. It's a relatively inexpensive way, and I think it's a better way to sample than the way most internet studies are done with this population, which it goes to GLBT listservs now, where we got a more random sample. But we can't always verify the data. So there could be some 40-year-old men. We don't think so, and we've called a lot of our women, and they are women when they answer the phone, but you never know. Okay? We've done our best to get the 40-year-old men out. All right? In terms of future directions, I really, really think there is a huge need for more studies, especially for bisexual women. We're seeing that this is a high-risk group, and we don't know very much about their lives. Okay? It's really going to be important, especially seeing some of those findings, to look at the changes in drinking over time, okay? And maybe thinking about possible subtypes. I also think it's important to think about proximal versus distal relationships. You know, right now everything's cross-sectional, but looking at that daily diary data, looking at how that shifts over time is going to be important. And I also really want us to think about resilience. There's a reason why I use the word brave in the title. Right? To be honest with you, I'm actually kind of surprised that the rates of mental health distress aren't higher given the degree of stressors. Right? We often talk about things from a deficit model, and I think it's really important to talk about strengths. Okay? As a way of thinking about that, and I'm not going to go into this in very much detail, this is actually a lovely model, and we will be able to test this, which really thinks about possible mediators and about things like community, how you make sense of your experiences as possible risk factors and resiliencies. Okay. So I want to share with you a few words just to wrap up. Hillary Clinton, I don't know how many of you heard this, gave an address to the United Nations this year about the needs of lesbian, gay, and bisexual individuals. She said, "I want to talk about the work that we have left to do to protect one group of people whose human rights are still denied in too many parts of the world today. In many ways, they are an invisible minority. They are arrested, beaten, terrorized, even executed. Many are treated with contempt and violence by their fellow citizens, while authorities empowered to protect them look the other way, or too often even join in the abuse. They are denied opportunities to work and learn, driven from their homes and countries, and forced to suppress or deny who they are to protect themselves from harm. I am talking about gay, lesbian, bisexual, and transgendered people, human beings born free and given bestowed equality and dignity, who have a right to claim that which is now one of the remaining human rights challenges of our time. Because for many young people, this is simple. All people deserve to be treated with dignity and have their human rights respected, no matter who they are or who they love." Thank you. What questions do you all have? Sharon.
I have a question. I'm just wondering if you were able, or you can step looking at the geographic distribution of the participants, because I think maybe you were seeing lower rates, maybe the people are from the States. Just purely have
So we have a wonderful epidemiologist who has joined our stats team, and Isaac has promised to first author that paper.
You know, in years past, I was told to be sensitive to domestic violence issues in lesbian relationships because there was a higher incidence of domestic violence being found in lesbian couples. But I didn't see that under the trauma stuff, and I was wondering if that had sort of changed.
I think that there certainly have been concerns about domestic violence. I think the literature is just not well done yet enough to know. And I'll be honest with you, for our data, we actually didn't ask about gender of the perpetrator, in part because that's not really our focus. We're looking less at that. It's something we could ask in future years. That's one of the nice things about a longitudinal study is each year we get to say, what do we wish we had asked last year? And we can shift some things slightly. But I think it's a great question. Sorry, guys. All right, other questions? Jessica?
So you use the Young Adult Alcohol Consequence Questionnaire as your measure of consequences, is
Mhm.
that right?
Yeah, we use Jen's measure.
Okay. I'm not as familiar with that as like with the RAPI or some of the
Yep.
other measures we use in our lab, but I'm wondering if maybe you didn't see higher rates of consequences because it wasn't accurately gauging all of the possible consequences that'll reach this. Like many of our measures are college focused.
Yep. So,
What do you
yeah.
think about that?
I mean, that's always possible. But we also use Tonda Hughes' measure of hazardous drinking that's been used in some of these things, and we didn't get much there either. And part of why we chose Jen's measure is it's actually, if you can believe it, longer than the RAPI and has subscales. So it's possible, but I would say it's about 70% accurate that we see what we see. But it'll be interesting to see over time, and we've certainly got people in there who are on the higher end. So, other questions?
Thank you, Deborah. Come back again.
Thanks, that was great.
Thank you.
That's wonderful. Are your slides available by chance?
I can send them to you as a PDF file.